So everybody is refreshed and revived after eating a diabetic diet. So we're on to the last part of our talk this morning, and we'll just focus here on the specific identity. Now before we go on to that, perhaps if I could just briefly talk again about the camera and some advantages that the camera will have in your primary care setting in comparison to doing a cystoscope fundoscopy. As you know, the camera has images, and those images can be stored. So the advantage is you can actually show your patient then and there diabetes damage in that patient's eye. So when you're explaining the type of retinopathy they have and how severe it is, you can actually show them the photo, and they will be able to understand it a bit more better. And if they do need laser, you can take the photo before the laser, and you take it again after the laser is completed. Sometimes if vision does not improve, you can actually see the evidence on the photo that while the diabetic retinopathy has improved where you have lasered, it's started again somewhere else. That is why vision is still the same or it has gotten worse. Okay, so photos have that advantage. You can recall them, you can bring them back next month, next year for comparison. You can even use it to educate the patient and their family. And again, you don't have to go and bend and look into the patient's eye and trip over and fall on their face. You just sit back and just click, and the camera does everything. You look at the photo yourself and you grade. And that's when you use those grading guidelines that we put up. It's much easier. The patient is not uncomfortable because of the bright light. You can take your time grading the photo. So again, camera, not only is it more sensitive and specific to picking up diabetic retinopathy, it's a cost-effective measure. How much do they cost? Oh, how much do they cost? The different cameras that are coming up on the market, they're getting smaller, they're getting more portable. So the price range, I think, 10 to 5? 10 PG. 5 US, I think someone is trying to market his camera, 5,000 US, a smaller one. And we have to get it sometime this year or next year to try it in PG. This year? Next week. When he comes to exhibit. Yeah, so they have websites that you can search, but they're getting smaller and they're getting portable. So so you can take it out in your twin cab and go out. I don't know yet about the boat. Not sure. Okay, so from this morning you know now the times to refer your patient as early as possible. Different times for type 1 and type 2. Never depend on the patient's vision for your referral. Okay, so now I will just talk briefly on some of the patients that we have seen that have come through our eye clinic. And also earlier this year I did a short audit on our screening. We did outreach screening to just down the corridor to our CWM SOPD. And our screeners went there and picked up all the diabetics that we've been seeing and photoed them there at the clinic because it was so hard to just walk up 20 meters to the eye clinic there. So that's the talk, the last talk this morning. Okay, just briefly again, facts that you should know. Blindness due to diabetic retinopathy is avoidable. That means it's treatable or it's preventable. Again, through early screening and early treatment. Diabetic retinopathy is the leading cause of visual impairment in working age adults, and in Fiji that's less than 55 years. 55 is our retiring age here in Fiji. But it's also the second leading cause of general vision impairment in Fiji, and I'm assuming that it's the same in the region. Okay? So either it's the second, because cataract is always the leading cause, or it's up in the top 3 in the region. So diabetic retinopathy is really something that we should focus on because of the first statement, it's avoidable. And looking a bit at the figures, now we had a study done in 2009 in Fiji. It was again a rapid assessment of avoidable blindness. And from that study, they found a prevalence rate of about 44% of adults over the age of 40 years to be diabetic. That's quite high. You see the different steps survey, some of you might have heard in the different countries. In Fiji, that STEP survey looked at over 25 years and they thought it was 16%, so they came to that conclusion. But our rapid assessment of blindness came with a prevalence of 44% over 40 years. And on top of that, 63% were undiagnosed. Okay, so you people have a really big problem to go and tackle when you go back, because I'm sure it's the same across the region. Now we should all know that all diabetics are at risk of developing diabetic retinopathy, whether it's type 1, type 2, gestational diabetics, whatever. As long as you have diabetes, you are at risk of developing diabetic retinopathy. And it's also shown from studies abroad and also here in Fiji, at any one time, about 1/3 of the diabetic population will have some form of diabetic retinopathy, whether it's mild or moderate or severe or proliferative. 1/3 at any time will have diabetic retinopathy. So when you're in your clinic, you must always remember, okay, 1/3 of my diabetics have some form of retinopathy. And out of those with retinopathy, or out of all your diabetics, 10% will have sight-threatening retinopathy. And those are the ones that should be referred very early so they can get that early treatment. Yeah? Now if you look at the clinical modifiers that were spoken or presented already by Dr. Tarai, sorry. Okay, this was the study or the audit that I did at our SOPD clinic, and this was done from February to May this year. We had a total of 166 patients that were screened, and just looking at their risk factors. Now these are patients seen by the medical doctors here, the consultants, the registrars, and of course if it's a tertiary hospital, you'll suspect that most of the patients referred here are the complicated ones. So we're just looking at the glucose control, and we looked at the cutoff level of 7% for glycosylated hemoglobin, or 7 millimoles for random blood sugar, and we see only 18% have good control. Look at the poor control, 75%. The people on insulin, people on both oral, yeah. So we see that a big percentage, 3/4 already, have one of the biggest risk factors of uncontrolled glycemia. Again, another risk factor, hypertension. 39% of our diabetics had associated hypertension, 1% high blood lipids, and again, just under 1/3 have both. So these people are at high risk of not only having a rapid onset of retinopathy, but also a quick progression from mild to proliferative. Now we look at the associated complications of macrovascular disease, peripheral or foot sepsis, 10-15%, that's straightforward cardiac 4%, anything wrong with their renal system, those that have had stroke. So our diabetic population, they're at risk of getting many other diseases. So when you're treating your diabetic, you're treating the person as a whole. You're looking at all the systems. You're looking at the eye, the heart. But the good thing is that the risk factors are all the same. So when you're advising for one, you're probably advising for all the other risk factors. Okay? Okay, when we look at the visual acuity of that, the 166 that we measured, 60%, more than 60% have no vision impairment. So maybe that was why they didn't come to the eye clinic. Maybe that was why they didn't complain to their medical or the physician, because most of them had no vision problem. There were a few that had severe and moderate. These are probably people with cataract. Yeah? Go on. Now, after the photo was done on that group of patients, even though 60% had good vision, these two are sight-threatening. And we've already got 25% with sight-threatening retinopathy that had not presented yet or who were not referred for an eye screening. And these were just picked up because our screeners went down and took photos. So if we hadn't gone to that, taken that step, these people would have continued whatever they were doing and would have presented much later. That was for macular grading. And then looking at the peripheral grading, again, just close to 10% with severe or proliferative retinopathy, which is roughly equivalent to what the figures we had showed earlier on. About 10% will have sight-threatening retinopathy. Yeah? But see, this good news is there's still a lot that have no retinopathy in the periphery, but these are the ones that we are concerned about. Okay, referrals from that from those 3 months, about 40% were referred to our ophthalmologist clinic. Out of that, 31, or just under 1/3 of them, were booked straight away into laser. And you think this is just within one hospital. SOPD is just down the corridor, the eye clinic is up the corridor. What about those that are on another island? Yeah. What about those that are in the rural? This is just within CWM, so of course the problem will be a bit more severe in your setting. So just under 1/3 were booked in for laser from the doctor's clinic. That was the result of that screening. Oh, okay. Okay, these are just a few cases that we came across. This is the photo of a 21-year-old. She's a type 1 diabetic. Good vision, 6'9", 6'12". And she was seen again, picked up by our screeners. Young girl still in, well, now, this was the photo that we took at her first visit. And if you remember back from the slides this morning, there's so many blood vessels, abnormal ones at the disc. Yeah? And we can already see pre-retinal hemorrhages. That's a sign that one of those abnormal blood vessels have broken already, and it's bled. Her vision is still good because her macula looks okay at the moment. Yeah? And the bleeding hasn't covered the macula, and there are no exudates that have caused swelling. That's why her vision was still 6'9". Yeah? Look at all this. Okay, go back again. That's a different one. So this young girl, only 21, type 1, she's had it for more than 15 years, her diabetes. She's been on insulin. And if you remember back to the referral and the referral processes, any type 1 diabetic has to be seen by a doctor if they've had type 1 diabetes for more than 15 years, regardless of what you see in the fundus. Okay? Type 1 diabetic, more than 15 years, send them to the eye doctor. Okay? So this girl is now overseas. She's going to get treatment done. And that, again, first photo at first screening, already R5. Yeah? Okay, this was another one, 47 years old female. She's working. Diabetic, 15 years. See her vision? Not too bad on the right. It's actually normal on the right. Left one 630, so some decrease in vision. Now she came because she thought her decreased vision was due to refractive error. She wanted her glasses changed. So she went down to the optometrist. Optometrist sent her up to get her diabetes checked, and that's why she came for photo. And then that was the grading we saw. The right eye, R5, is severe. Hang on, it's proliferative retinopathy. And we have mild maculopathy on the right eye. Left eye is advanced. Yeah? Advanced retinopathy, R6. N4 is severe maculopathy. Okay? So on that first visit, we advised her that the left eye had to go abroad for treatment. It was too advanced. But while waiting for all the discussions and organizations, we started doing therapy in her right eye. And that's a photo of the right eye. See how good it looks? So not really. Remember your hemorrhages, blocked and dot hemorrhages, your exudate. Macula looks quite good. That's why it's only M2, mild. Yeah, but if you look in the periphery, that's where you see the blood, abnormal blood vessels growing. This is her left eye. You see fibrosis. And fibrosis is like cotton wool, like cobwebs. Yeah? And under that, you have all these new blood vessels. And she had a whole band of fibrous tissue going down and going up. You see her macula. The center is already threatened. so she had to go abroad for treatment. We could have done laser here, but vision prognosis is poor, and with that fibrosis band contracts, could precipitate a detachment. So again, she was really young, 47. Okay, this is another type 1 diabetic, but she's actually 45 years old, working down in a shop and she presented in January for blurry vision. Again, blurry vision, so she wanted glasses. Her sugar was pretty high, 15 even with insulin. That's a picture of her right eye. And again, look at the macula. Being exudate there, that's already vision affected. Vision won't come back with that plaque there. Again, peritoneal hemorrhages. So she's been followed up. She's on insulin, so of course every month she'll be seeing her GP, her doctor. But that was the first time she came for a night check. That was her right eye. That's the other nasal view of her right eye, just to show the blood vessels in her vessel. This one. That's her left eye. Same picture, not as bad as the right. Macula is already getting a far close. So when you see that, you know that there will be swelling around here, and the vision will be affected. She's got new vessels as well. And we started laser in her right, in her left eye, and her right eye. But before we could finish the laser, she bled. Yeah, new blood vessels broke, and then she had a bleed. And then we had to hold on the laser for a while. Once there's bleeding, we can't do laser because our vision is, obstructed from that hemorrhage. So now she's trying to make arrangements to go abroad, and she's only 45. She's completely better. And now, what's now? It was October. In January, when we saw her, we had explained everything to her. And then at her last clinic, she actually said in her own words, "Yes, my vision is really affecting my work. I'm trying very hard now to go abroad, just to get that sorted." Yeah. Okay, this is another lady. She's Fijian, in her early 40s. Early 40s, diabetic, hypertensive. Control, going to her clinic, but this is the first time she came to our clinic because, again, doctor, I've got blurry vision, I want to have glasses. Okay. And this is a photo. Now, if you remember, trying to recall our class, the talk this morning, venous beading, up there, sausage-shaped vein, yes, venous beading, that's a sign of severe retinopathy. Cottonwool spots everywhere. Cottonwool spots not really indicative of the severity of diabetes, but it shows that there's something else going on, like high blood pressure. And you mightn't be able to appreciate, but see how thin her arteries are. And look, it's like a blot. And that's all signs of the severity of a microvascular disease. So she's got diabetes in combination with high blood pressure. She's also scheduled for laser. She's having laser now. She's a pretty educated woman. I think she was a school teacher. That was the photo. And that's just another view of her same eye. All the new vessels. Alright, so, again, we cannot overstress or stress enough the importance. All diabetics, they're at risk of getting retinopathy, therefore, they need to have screening. And according to our guidelines in the Pacific, because we know our Pacific Islanders love their diets and hate their exercise, 5 years after diagnosis of puberty for type 1, type 2 at the time of diagnosis. Yeah? If they're type 1 and they're not sure about when they started getting diabetes, assume that they've had it for 5 years, send them for a check. Yeah? Again, gestational diabetes at diagnosis, and if they're diabetic and pregnant, as early as possible in the first trimester. Because if you see them in the first trimester and it's only mild, by the time they're in the third trimester, it could be proliferative. So they need to be referred early. Okay, proper screening for retinopathy. The aim WHO aim is to aim for 80% sensitivity and specificity. And of all the studies that have done abroad and locally, they found that the retinal camera is the best way to get that 80% sensitivity and specificity. So if you're talking to your government, don't just say I'm wishing for high tech. It's actually documented in literature. Yeah? You can do other things like direct ophthalmoscopy or indirect. That requires a lot of training, and you'll get better as you keep doing it. But you know, the 20% failure rate from the camera is usually because of medial opacities and small pupils, and that can be counteracted. If you think the pupils are very small when you're taking the photo, then you'd have to dilate the pupils and do another photo. Right? If there's medial opacities, then of course you just have to send them for check with an eye doctor. And again, good dilated fundoscopy. If you don't have the camera, preferably slit lamp indirect, but I suppose that primary healthcare level, you'll just use the direct ophthalmoscopy method. But remember, out of all those methods, it's the least effective. Okay? Thank you. That's our camera day. Any questions? Okay, she's a nurse. He's not a nurse.
Nurse for me.
Sorry?
Nurse for me.
Tonga nurse. Tonga nurse. So for the camera, you know, it doesn't have to be a doctor, it doesn't have to be a medical personnel. Usually the doctors don't do the photo, the nurses or the mid-level personnel. They do the photo, they grade, and they refer. So those are just some tragedies of what could happen if you let your diabetics just go through without referring them or without checking them yourself, checking their eyes. It's understandable. It's difficult to examine the eye in the periphery. So send them to us. That's what we are there for. Okay, any questions?
Can someone help you for the senator? That's what the message
The question, okay, so remember, you know, this, and now we are seeing a lot of younger diabetics that are coming in severe. These are the ones that are coming in needing laser straight away, but we have so many more that are coming in with severe retinopathy. First time, vision is still good, that's why they're not coming in. Question? You want to start the weekend already? No question? Yes,
How long is the training for the camera?
Camera, the nurses,
Yeah,
the training,
like
6 months. 6 months, they have lectures, they do practical, they have to do assignments, they go to Lotoka, they split, some go to Lotoka, some stay here, and then they change for the practical part, and then they have exams.
Just out of interest, what do they do overseas? You know, just out of interest, what do they do overseas?
When you refer them? Okay, what do they do? That's the question. What do they do overseas when you refer the patient? The main reason we refer is because we don't have the services available, so it's surgery. They do surgery at the back of the eye. Vitrectomy, they do endo laser. We don't have the equipment here. We don't have the human resources that are trained here. It's a fairly expensive setup, and it needs really good training. So we don't have that service yet. So any posterior segment surgery is referred over to diabetes trauma.
Do you do cataract?
We do cataract, yes. All the doctors that you send for training at the Pacific Eye Institute postgraduate diploma, they have to do 100 cataracts before they can graduate. So when they come back home, they can.
So when you do cataracts, do you insert a lens?
Yes. Remove the cataract and put in the artificial lens.
Is it not cheaper to get the eye surgeon to come here and perform surgery in the future?
That's true, but we don't have the equipment if we have to invest, and I think talks are currently underway to get it done as well in the Pacific Eye Institute, because we regularly have specialists. You know, in eye, it's not just an eye doctor. You have different specialities for the eye. You have the doctor that does cataracts only. You have the eye doctor that deals with corneas only. You have doctors that deal with the vitreous and retina only. And even that, you have the doctors that deal with the medical part of the retina and doctors that do surgery in the retina. So it's really highly specialized. But those specialists come a week, 1 week, go back. So if that unit is up and running, it will probably be for the Pacific. It's still all in its infant stages.
Very soon we'll have the next eye specialist in the right Training for the camera, is done every year?
Sorry?
The training for the camera is done every year?
For the
And
next-
sponsor it?
You have to find your own sponsors. If you can get sponsorship from your government or WHO, or just write it to the Pacific Eye Institute. They might have a list of sponsors to give to you. Okay, suppose we should just talk now about the Pacific Eye Institute. This started back in 2006. It started in the Solomons, but because of reasons, they relocated to Fiji. So in 2007, we started up at Kamagua. Then there were 2 clinics running. The clinical part was held here in CWM. The lectures and the refraction was done up at Kamagua. And then everything came together and we moved down to Brown Street in December last year. And that's where we are now. The teaching institute, the operating theater, the administration building, and the clinic is all down at the Brown Street Clinic. Now the courses we offer the postgraduate diploma for primary eye care. That's the one for nurses. You can do a whole year course. That gives you the postgraduate diploma. That's done in different modules. Eye theater module, primary eye care, and all the other modules that I can't remember. But for countries that are not, probably the smaller countries, they offer a 6-month certificate, postgrad certificate in eye care. That's when you will do probably only 3 out of the 6 modules or something. And that gives you the postgrad certificate. Now all these nurses, and you don't have to be a nurse, you can be a technician as well, have some background or interest in eye care. They all learn how to refract. So whether you do the certificate or the diploma, at the end of that you'll know how to check for glasses and how to dispense glasses as well. Because that's a very common problem in everyone, refractive error. For the doctors, we offer the postgraduate diploma in ophthalmology. That's a year. And as I said earlier on, by the end of that year, you should have done 100 cataract surgeries. There are different methods of doing cataract surgeries. You start with a standard, learning the standard procedure, then you go on to small incision where you don't put stitches on the eye. That's what the students are doing now. But we do not offer phaco classes in the diploma stage. After that year, you can progress to the Masters of Medicine in Ophthalmology. And these are all clinical based. You have exams, every 2 weeks, every 3 weeks, depending on the reading that you are given. And you have a logbook to fill, the nurses as well. So it's pretty intense. But they have a resource center, you have books, they have access to internet. Yeah. And I think they actually give equipment as well. So if you're coming in as a nurse, you get your own ophthalmoscope and retinoscope set. You get your own tri-lens set. And that is to help you when you go back to continue doing eye care. So really, I think it's for your clinic. Probably not for you personally, but that never happens. And also, you get the resource material, all the textbooks. If you're a doctor, you can get a laptop. Funding, I think it's around, 10,000, 8,000? That might change depending on inflation, etc. But Fred Hollow's Foundation of New Zealand offers a couple of scholarships for students to study. So if you're coming from the region, that includes tuition, that includes your housing allowance, stipend. If you're a local, that just includes your tuition, nothing else. For diabetes care, eye care, that just started last year. It started with a group of nurses and mid-level personnel. 6 months again, in fact, was it 6 months or 1 year last year? 6 months last year. Okay. And at the end of that, you get a postgraduate diploma in diabetes eye care. Did they get equipment? They would have gotten some sort of equipment. And with studying at Pacific Eye Institute, they also offer, after you graduate, they don't leave you to go and struggle in the rural or in your own stations. Someone from the Fred Hollow's Foundation actually goes out maybe once or twice a year to see how you are doing. Yeah. We have regional eye care conferences every year. So every student that has gone through the Pacific Eye Institute gets the opportunity to come, present the work that they are doing, present the challenges, and that's also a time when Fred Hollows can see whether they can help them in their own station. Of course, all paid for by good old friends. What else do we offer? Oh, the nurses, they're just doing the postgraduate diploma now, but I think they will start the masters pretty soon as well. For nurses that complete the diploma, they can go on to do the masters. The doctors already have the master's program running, and the first students will graduate next year. And it's a similar program to the one running in FSM, where the diploma is the first year of the master's, and you have another 2 years of clinical, and then your 4th year is a research project where you get to conduct a research and present it at the end, and you also get to do attachments, whether it's local or abroad, when you graduate at that 4th year. Services. Pacific Eye Institute runs in conjunction with the eye department of CWM. We have general clinics every morning from Monday to Thursday. Booking system. So you have to make a booking, but you can make allowances for you lot that want an eye exam. Afternoon clinics are generally our special clinics. So we have our diabetic clinic, our glaucoma clinic, our pediatric clinic. Those all run in the afternoons, 2 to 4. We have theater, runs 3 days a week, both for major theater and minor theater. We have a refraction clinic where they specifically concentrate on glasses. That's every day. And they also dispense ready-made glasses, both readers and distance. And they sell those glasses $10, depending on the type of glasses you choose. Might be 10, might be 15, might be 20.